Good evening, Rasik sir.
Good evening, Dr. Prabhu.
Yes, sir.
All well?
All well, sir.
Good, good.
Yes.
Good evening, sir.
Jaya Kumar, Mr. Jaya Kumar.
Good evening, sir.
Good evening. How are you?
Fine, sir.
Nice to see you.
This guy has copied that entire hydrocele repair from you, sir, and he's doing fine.
Yeah,
He's our
I,
guru, man.
I had that good opportunity to be teacher, mentor for many, many people.
very few of us do this laparoscopic hydrocele repairs and all, sir. Not many of us, even I am very few of us. So in that we pick few who can.
But there is no reason to differentiate between hydrocele and hernia. Both have same etiology except the size of the opening. Very rarely it is like adult hydrocele. Or in fact, in my last 23 years of laparoscopic repair, only one patient had something like adult where we did not find the internal opening.
Mhm.
Maybe a secondary hydrocele, sir.
Maybe
a secondary hydrocele.
Yeah, that was secondary hydrocele because the sac was very thick in that particular patient, and obviously it was secondary. But of course, we started with laparoscopy, did not find internal opening, and did standard repair.
You did it by by scrotum or inguinal opening, sir?
We did it from inguinal, I think, or scrotal. I can't recollect it right now, but I can access the paper and see. I must have done inguinal. I think inguinal delivered from because that was again long back, maybe 5-6 years. Long means 5-6 years back.
If the sac is patterned up to the deep ring, we can explore from abdomen itself, sir.
Yeah, it was more of scrotal swelling. It was a
Scrotal, yes,
6-month-old child,
yes, sir.
which we operated. And then from inguinal area, we delivered and did whatever needs to be done. Yeah, I was working in the background doing something else. So once the meeting starts, I'll.
Good evening, Rasik sir.
Welcome,
Good
Dr. Rasik.
evening. Good evening, brother.
Good evening. Oh, our chairman, the great Dr.
Good evening, sir.
Dr. Prabhu is there.
Huh? Oh. Oh.
So we have come online before time.
Yes, sir.
Everybody is keen to listen, Mr. Prabhu, with international participation.
Yes, sir.
Just be back in a while, sir.
Actually, you should start the recording when actual event starts. Because otherwise you need to edit this first 10-15 minutes of recording. So you have already started recording, but you can stop it and re-record when the meeting starts, so that you don't need to edit that part. Doctor, start.
Yes, sir. Yes, that makes, yeah. For the people, for our colleagues who have joined from abroad, away from India. So I would like to put on record, or just to let you know that most of the pediatric urology is being practiced practiced by pediatric surgeons in this country, almost 95 to 98% to get a rough estimate of it. And the complex pediatric urology always remains complex, and so that is why these monthly meetings are held by Society of Pediatric Urology, which is a subchapter of Indian Association of Pediatric Surgeons. So pretty much delighted. This is a season 2 where we have 5 zones in this country, where every zone we take up each month, and we discuss complex cases in those zones. For example, today is a South Zone. We are starting with South Zone, the season 2. So this is just to give you a brief introduction, and with the permission of the chair, Dr. Deepak sir, if I can hand over the proceedings to Dr. Rajendran sir
Yeah.
for the further.
Good evening, Prabhu and all. I welcome all of you to this first academic meeting of 2025. I'm Dr. Deepak Goyal. I'm pediatric surgeon based at Nagpur, and we do most of pediatric urology. I think without wasting much time, we'll start the academic program. I invite Professor Rajendran to moderate this session and to start the proceedings. Dr. Rajendran, please.
Just give me 1 second, sir. 1 second.
So just to brief you, Dr. Rajendran is a pediatric surgeon and an executive member from South. We have 2 chairpersons today. Dr. Rasik Shah is a editor-in-chief of Indian Journal of Pediatric Surgeon. And Dr. Sharif is from Cairo. Rajendran has joined?
Yes. I am here.
Yeah, sir. Start, sir.
Just a minute.
Respected Chairman, Dr. Prabhu Goyal, Secretary of Society of Pediatric Urology of India, Dr. Prabhu, our moderators, our chairpersons, Dr. Rasik, Dr. Sharif, our speakers, participants. I have great pleasure to welcome all of you to this academic program of Indian Society of Pediatric Urology. This turn is of South Zone. Because I am the South Zone coordinator, South Zone Executive Committee member, I got the chance to moderate this, and thank you very much. In this academic program, now from the beginning, let me remind you that our academic programs of Society of Pediatric Urology has now become international DSPU, with the participation of faculty from abroad, from all over the country. This is the first international decoding of Society of Pediatric Urology scientific program. We have today two chairpersons. Dr. Rasik Shah. Dr. Rasik Shah is a renowned pediatric surgeon in India. He is the head of the Department of Surgery and Senior Pediatric Surgeon, SRCC Children's Hospital, managed by Narayana Health in Mumbai. He is a pioneer in minimal access pediatric surgery and pediatric oncosurgery, as well as pediatric urology. He is past president of Indian Association of Pediatric Surgeons. He is the current editor-in-chief of Journal of Indian Association of Pediatric Surgeons, which is the official journal of Indian Association of Pediatric Surgeons. He has given many lectures, published articles in various journals. He has a YouTube channel. He is the course director of Institute of Medical and Minimal Access Surgery Training Center in Mumbai. Has a US patent on a laparoscopic device. So he is an eminent pediatric surgeon and a urologist from India. I am happy to introduce another chairperson. He is Dr. Sharif M. Suleiman. We are happy to participate this international faculty in our meeting. He is the consultant, pediatric surgeon, and clinical head of Pediatric Urology Division in the Department of Pediatric Surgery, Faculty of Medicine and Children's Hospital, Ain Shams University, Cairo, Egypt. We are proud, Dr. Sharif, to have you with us as one of the chairpersons.
Well,
We
it gives
have
me great pleasure
presentations.
with you.
Pardon?
It gives me great pleasure to be with you.
Thank you,
for
thank
the
you.
invitation.
Thank you. Now we have today three presenters. Dr. Muhammad Imran will be the first presenter. He is from Government Medical College Trivandrum. He is a second year MCH resident trainee in pediatric surgery. He will be first presenting the follow-up of a previously presented complex urology case, followed by his presentation of new cases. The second presenter is Dr. Bhavana. She is second year MCH trainee from GSI Medical College of Hyderabad, Telangana State of India. The third faculty is Dr. Jaykumar. He will be presenting on a special topic of laparoscopic repair of hydrocele. He is assistant professor in Government Medical College, Salem, of Tamil Nadu State of India. With this brief introduction, I am very happy to hand over the chairs to our great chairman, Dr. Rasik and Dr. Sharif. To you, sir.
Thank you for the opportunity to chair this particular session. Can I invite the first speaker?
Dr. Muhammad Imran.
Yeah,
Yes, sir.
Mohammad Imran, please go ahead with your presentation.
Can you able to see the?
Yes.
We
Yeah.
can see, yes.
Oh, good evening, faculties. I'm Dr. Imran from Government Medical Trivandrum. My guide is Dr. Beena, madam. So, coming to the previous case summary, a term female child with an antenatally detected bilateral hydronephrosis and cross-fused ectopia with Cori duplex collecting system. Postnatally, she developed dearranged RFT and had a failed catheter drainage with pericatheter leak. Later, developed a complicated left hydronephrosis, urosepsis, and pyonephrosis. So, initial management include cystogenioscopy that shows small capacitor bladder with no identifiable ureteric orifice and ill-defined trigone. Left orifice identified below the bladder neck, for which left end ureterostomy was done. Right ureteric orifice is not identified. So, intra finding were grossly dilated and bulbous left ureter with abrupt tapering down and negligible bladder. So, we proceeded with imaging and MR urogram and DMSA done, and it confirmed the mal-rotated right duplex kidney with ectopic ureter insertion into the upper vagina with hypoplastic bladder and cortical scars in the both kidneys. Later, child also underwent right end ureterostomy due to recurrent infection, urosepsis, and fourth right. Renal function eventually stabilized after diversion procedure. At 3 years, child remained UTI free with a normal renal function, now awaiting for definitive urinary reconstruction. This was a case presented previously. So what we did is bladder cycling was attempted by saline installation, but it was not possible because normal saline was not retained in the bladder since it's a small capacity bladder. So what we did is we inserted a Foley's catheter. We increased the bladder capacity by slowly inflating the Foley's bulb gradually from 3 ml to 15 ml. So after getting some adequate amount of bladder capacity, we proceeded with right ureteric reimplantation with left transureterostomy. So the image what we can see, this is a cut open bladder with Foley's bulb in situ. This is a right ureter and this is a left ureter. We did this right ureteric reimplantation with left transureterostomy. This is a second week post-op ultrasound that shows bladder with stent in situ. The bladder volume is around 12 cc. And this is the dilated ureters. This is a 1 month post-op ultrasound that shows a few enlarged capacity of bladder, which shows around 24 ml of bladder capacity. So at present, 3 month post-operative period, the bladder capacity is around 25 ml. There is no PVR. Child is holding urine for 1 to 1.5 hours. There is no incontinence. There is no UTI. And child is on anticholinergic treatment. So this is the end of the first case.
Thank you. Thank you for, it's a very nice, challenging case, having bilateral ectopic ureter where bladder capacity is small. One question from my side. I suppose initially when you did cystogenitoscopy and left end ureterostomy,
Yes, sir.
you probably did not know that bilateral ectopic ureter is present. Otherwise,
Yes,
one can do just, suture the end of the ureter with whatever bladder we have. We may not be
Okay,
able
sir.
to do ureteric reimplant like, with tunneling, but one can do primarily that instead of doing end ureterostomy. So is the same, I mean, that was the situation or it was planned end ureterostomy?
Pardon, sir, I couldn't hear.
My question is, why did you do end ureterostomy instead of suturing end of the ureter with whatever bladder you have?
So, sir, bladder was very small capacity, so we couldn't able to do a reimplantation during that time, initial time.
So
And also child had urosepsis, and when we are opening the ureter, there was a lot of pus was coming out, sir. So we moved out, we go on with the ureterostomy.
Okay. Dr. Sharif, you have any questions for the presentation?
Yeah, I have a question about the other side, the left side. Was it a duplex system as well or not?
Yes, sir. It's a duplex system, sir, but both ureters are joined together before it enters the bladder, sir.
So it's technically a single system when going to the bladder, right?
Yes, sir. Yes, sir. Yes, sir.
And you couldn't identify the orifice. And where was the orifice
The
draining
left orifice
eventually?
was left orifice was like too far below the bladder neck, sir.
Yeah, so probably that's why you have a small bladder. And I
Yes.
quite agree with your management, actually. It's a damage control or a salvage surgery followed by
Yes, sir.
reconstruction. And I really admire your approach in attempting to increase the bladder capacity. However, I think one has to be vigilant on the long term, especially in the first few months after the procedure and then the first few years, because
Yes, sir.
some of these bladders usually don't respond well, even when you start recycling them, when you force your way in by what you did with the Foley's catheter, and apparently you have an increase of up to 25 mils.
Yes, sir. Yes, sir.
However, some of these bladders actually fail to grow further with recycling. So I would be having a very low threshold for diversion in this kit down the road. Thank you so much.
Thank you,
Yeah.
sir.
So at any point, augmentation can be considered in such a patient.
Yes, sir. After the child grows, we can check for the bladder capacity, and if the bladder capacity normal, and if the child is able to hold urine for 2 to 3 hours, we can proceed like that. And if it is not there, we can plan for augmentation, sir.
Okay. Any questions from delegates? What is the normalized GFR? Is the query from Dr. Sumitra Bishwas. So at this age, what is the GFR you expect? And you must have done renal scan, or it is to be done.
It is done, sir.
So what was the GFR, if you can tell us?
Sir, only DMC which shows only the function, sir. GFR, it was not there. Left side was 45 and right side was so right side is 45 and left side is 55%, sir.
Okay.
What was the serum creatinine, by the way? If we were to
So
explore
initially
this,
RF dearranged, sir. Like creatinine was at a higher side. After diversion, it came to normal, sir.
how much normal is and how much the weight, because in the first 2 years of life, you need to correlate this with the bladder mass, actually. And the usual calculation through DTPA or MAC3 is not that accurate. Even if you try the bedside Schwartz formula, it's not accurate as well. So you need to correlate this with the body mass. Sometimes it's normal, it appears normal, but with the small body mass, this means that you have a significant compromise of renal function. So what was the number that you had, and was it the weight of
Initially
the
2 to
child?
3, sir. So initially it was 2 to 3. Then it came to normal side, sir. After diversion.
Okay, that's good.
Okay, one more query which I have. How long it took for bladder to grow using Foley's, and what exactly you did? Which size Foley's you used? How much inflation was being done? It was 24/7 or it was intermittent? Can you tell us more about that?
Second ureterostomy was done at 6 months of age, sir. So from 6 months, intermittently we are inflating the we started with 8 French Foley's catheter, sir. So
Okay.
we started inflating the bulb gradually from 3 ml. So we retained the catheter for like 6 to 7 days. Then we removed, and it was like gradually we are doing the procedure, sir. So at last we can able to put the 10 French catheter, and to 15 cc of saline can be installed, sir.
So when you say
It took around 2
intermittent,
years.
yeah, intermittent meaning how many hours per day? Like
We
anything
catheterized the
but
child for 1 week, sir. Then then child was in off catheter for another 2 weeks. Then we like intermittently we were using the
okay.
catheterization,
Okay.
not continuous, sir.
Yeah, and can you tell us more about re-implant? What exactly was done? What was the length of the tunnel? This is a query from Dr. Narendra Babu from Bangalore, Indira
Yes,
Gandhi Institute. Yeah.
yes, sir. So initially we opened the bladder, and initially peritoneum was opened. So but we able to go extra peritoneally, sir. So we did the reimplantation extra peritoneally, and we got adequate length to reimplant also.
So when you call it as adequate length, what was the diameter of the ureter at that point, and what was the tunnel length, if you remember?
Sir, ureter length was approximately 18 to 20 millimeters, sir, when we reimplanted.
Did you taper it?
No, sir, we just reimplanted there.
Okay. And what could be the length of the tunnel?
That exactly
You don't remember?
I wouldn't
Okay.
able to remember, sir.
So have you done any MCU or anything after the reimplant?
No, sir, MC is not done till now.
Okay. Yeah, that was again query by Dr. Narendra Babu. Do we have MCUG after the surgery?
No, sir.
Anyway, any more questions from any more queries from delegates, attending delegates? But the child does not have any more infection. That is good, and create has come down at the age of 3 years. We hope the child does well. Can we go
No,
ahead?
I
with-
have a,
Yeah,
can I
please.
pass a comment?
Please.
Now here, this is a bilateral ectopic ureters with the cross-diffused ectopic kidney.
Yes, sir.
One ureter was inserted into ectopic side bladder neck, other one into upper vagina.
Upper vagina. Yes, sir.
Even though one ureter was ectopic into the vagina, the child did not have dribbling of urine, isn't it?
Yes, sir.
And we could not detect it,
Yes, sir.
except with in MRU.
Yes, sir. Since it was a small size bladder, the child was having couldn't able to hold the urine initially, sir.
Okay.
That's
Can
all.
I,
Okay.
Rajendra, you want to ask anything?
Nothing.
No. Okay, this is a query to delegates. How many of you have seen bilateral ectopic ureter in your practice, in your clinical practice? If anyone has seen, just raise the hand. It's very uncommon. We had one child when I was resident, that is 1991, 92. So since then, I have not seen. Dr. Bishwas, you have seen?
Yes, I have 3 such patients.
Okay.
Both 2 patients are bilateral ectopic vaginal ureter, single system, and 1 patient is in bladder neck one and one in just above the bladder neck. So it is in the bladder, but just above the bladder neck. So the symptoms are dribbling.
Okay. My only query from all those who have seen, how many of their patients' bladder is doing well in long run?
One
Or
patient,
they had to, yeah.
in
please.
one patient, I have diverted it into the rectum with a operation which we called identical replacement of urinary bladder with rectum. That is a partitionized chamber for the urine and stool.
Okay.
The second one I have put into the bladder, which was approximately 10-15 ml, but it was a sand-filled anastomosis. So no ureteric tunnel.
Okay.
That child is under follow-up still, and the bladder is growing slowly, but it is just only 1 year back. So we need to have long run. In urology book, I can't remember the book. It has been told that not only these bladder fails to grow inappropriately, but also the kidneys are not normal. So in the long run, the kidneys may go into chronic renal failure. That's what I read. I will later on. I will, if I can remember the name of the book, I will send to this forum. Okay.
Okay. Thank you, sir. So I think five cases are there. All of you can join hands together and write a good paper on it. We will go on to second case. Dr. Serif, can you introduce this particular patient, presentation?
Again, the second presentation will be by the same person, Mohammed Imran.
Acha, okay.
Yeah, very good case from Bina Madam's unit. Wonderful. Please go
Okay.
ahead.
Please go ahead. Yeah.
Proceed with the first case, sir. Case of bladder diverticulum. So it's a term male child 2.9 kg with full term normal vaginal delivery, antenatal no significant history. Postnatal child urine stream was good. There's no history of UTI. Child presented with irritability and mass abdomen at 7 months of age at another center. So child was evaluated and got treatment in another center. So during that time, the mass disappeared on catheterization and further workup was done. So on evaluation, ultrasound KAB shows left-sided hydronephrosis with the bladder diverticulum, APD of 10 millimeter and ureter of 4 millimeter, and right kidney is normal. So MC was taken there that shows a irregular bladder with a huge bladder diverticulum and grade 4 BUR on the right side. So cystoscopy was done there. It shows a huge bladder diverticulum with a narrow mouth. Bladder neck is normal, veru and posterior is normal. So catheter was removed after 5 days of admission, and the child voided urine freely, and there is a good urinary stream visualized, and then child was discharged from there. So child again developed second episode of acute retention of urine. Sir, okay. Child developed second episode of acute retention of urine at 10 months of age, and presented to our institute, and again managed with catheterization. So we did a cystoscopy. So it shows a huge bladder diverticulum on the left side.
You can mute Dr. Bishwas. Yeah, please go ahead. Sorry. No, Imran, you are muted. Please unmute yourself.
Oh, sorry, sir.
Yeah.
So we have done a cystoscopy. It shows a huge bladder diverticulum on the left side. Right side, there is a small parauretal diverticulum. Veru and posterior are normal. So catheter removed and started on alpha blocker, and the child was kept under follow-up. We did a DMSA, it's normal, and there is no scarring there. So again, child developed third episode of acute urinary retention at 1 year of age. So again, we catheterized the child and we proceeded with a definitive procedure. So we proceeded with intravesical diverticulotomy with bilateral reimplantation. So intra finding was large diverticulum on left side, left ureteric orifice visualized after everting the diverticulum, and there's a parauretal diverticulum on the right side. Right ureteric orifice is below and medial to the diverticulum. So post-operative period, it was uneventful. Post-mortem residual volume is around 25 ml. So we started on alpha blocker. Then the PVR got reduced to 10 ml. Hence the child got discharged with alpha blocker. So post-op ultrasound after 3 months surgery, and right kidney is normal and H1 is resolved. Left kidney is normal. The PVR is less than 5 ml and bladder is normal. So going to the second case, it's a term male child, full-term normal vaginal delivery, antenatal no significant history. Postnatal there is a good urinary stream. So the child had developed 2 episodes of culture positive UTI at 10 months of age. So on further evaluation, urea creatinine was normal. Ultrasound KAB done at 1 year of age that shows mild pelvic calcium dilatation on the right side. Left kidney is normal and bladder wall thickness is normal. So we did an MCU. MCU shows bladder is normal and there is a grade 5 VUR, which we are seeing here, and there is a bladder diverticulum and significant postmortem residue is there. So we proceeded with the DMS at 1 year of age, and it shows 45% DRF on the right side with pyelonephritic changes in the lower half of the kidney. And left kidney is normal with 55% DRF. So again, we proceeded with cystoscopy plus circumcision at 1 year of age. So cystoscopy finding shows trabecular bladder, right ureteric orifice is not visualized, diverticulum present at the right side of the bladder, left ureteric orifice is normal, bladder, neck and veru and posterior are normal. So we started on a uroprophylaxis. The child lost follow-up for the next 2 years. So the child came for review at 3 years of age. The child is asymptomatic. Urea creatinine were normal. And we have done a MCU that shows a bladder irregular and the right grade 5 VUR with parauretic diverticulum and posterior urethra is normal. There is significant PVR is there. And cystoscopy and DMS also done. It showed the similar finding of previously. So we provisionally diagnosed of neurogenic bladder with the VUR and parauretic diverticulum was made and the MRI spine was done, which shows normal study. So we started on uroprophylaxis continued, and again patient lost follow-up due to COVID-19. And patient after 5 years, patient reviewed at 8 years of age. So during that time, child was asymptomatic, urea creatinine was normal. Then ultrasound we did, and it shows a gross hydronephrosis with APD of 42 millimeter, and there's a significant parenchymal thinning, and ureter is around 25 millimeter on the right side. Left kidney is normal. Bladder diverticulum is size of 60 into 33 millimeter, and there is a significant PVR of 77 ml.
So we did a MCU and it shows a trabeculated bladder. You can see a trabeculated bladder and the grade 5 VUR and bladder diverticulum, and there's a significant PVR also. So we did a cystoscopy also, and it shows a heavily trabeculated bladder and a large diverticulum present on the right side. Right ureteric opening could not be made out, and the left ureteric orifice is not visualized. So bladder neck is prominent, and the veru and posterior urethra are normal. So again, we did a DMSA. It shows a 41% DRF and with the hydronephrotic kidney and cortical scar in the midpole of the right kidney. Left kidney is normal with 59% function. So CAC tried and it's non-compliant, and child again lost follow-up for another 2 years. Now the child reviewed at 10 years of age. The child is asymptomatic now, and ultrasound KUB shows gross hydronephrosis with tendon parenchyma, APD of 50 millimeter and ureter of 25 millimeter. Left kidney is normal. Urinary bladder appears to be irregular. And there is a diverticulum noted in the right side of the bladder of 65 into 48 millimeter. So and then we did the IVP. Then the IVP shows there's a duplex collecting system on the right side. So upper moiety has a mild hydronephrosis with a normal draining ureter, but lower moiety there is a severe hydronephrosis is there. In bladder with multiple trabeculation and outpoaching in the wall is there. So we did the MR urogram that shows a duplex pelvic collecting system with a severe hydronephrosis of lower moiety of APD of 31 millimeter and lower moiety ureter is 21 millimeter. Upper moiety renal pelvis and ureter are normal. So we can see the upper moiety normal caliber ureter here. And there is a parenchymal thinning, and ureter of both upper and lower moieties are seen joining at the distalmost part of the bladder. So left kidney is normal. So we did the uroflow. Total voided volume is 160 ml. Mean flow rate is 4 ml per second, and the flow time is 40 seconds. In curve there is a prolonged drainage of the urine is there, prolonged drainage curve. And the Qmax is normal. So UDS is not done for this patient. So summary, male full-term normal vaginal, term child full-term normal vaginal delivery with antenatal good urinary stream. Initially developed only 2 episodes of culture positive UTI at 10 months of age. So on evaluation, we found out there is a bladder diverticulum and there is a right sided grade 5 VUR. And the renal function is normal. So we started on a uroprophylaxis, and again the patient lost follow-up. On the next visit, the child was asymptomatic. There is a persistent right grade 5 VUR with the bladder diverticulum with maintaining normal renal function. Again, the child lost follow-up. Now at 10 years of age, the child presented, and the child is now asymptomatic. So on further evaluation, the child was now diagnosed as right duplex system. Upper moiety is normal. Lower moiety has a gross hydronephrosis with a grade 5 VUR. Ureter of both moieties joined distally, and there's a huge bladder diverticulum. So what we have planned is right lower pole hemi nephroureterectomy with extravesical diverticulectomy.
Are you done?
Yes, sir.
Yeah, Dr. Seri, please take over.
Well, it's quite a complex case to start with. I have some questions regarding the follow-up of this patient.
Yes,
So when you did your first cysto, you found this heavily trabeculated bladder. However, you did an MRI and it was normal.
Yes, sir.
And he has no visible clinical or neurological lesions. Right?
Yes, sir. Yes.
So where do you think these trabeculations came from? Well, I'll answer that for you, actually. This bladder is extra working, actually. It needs to propel urine to the outside. But it has this diverticulum, which is wasting all the energy. So it has to work more in order to propel urine to the outside of the body. So that's why you're having these tics, these trabeculations. Actually,
Yes, sir.
This diverticulum, this huge diverticulum should have been, addressed from the beginning if you could. I see that the patient is having a very hectic follow-up.
Yes,
so continuing on the follow-up to the age of 10 years, he lost a significant portion of his right kidney, I'm assuming.
Yes,
Okay.
yes.
And my concern with your plan now, this bladder now is a dangerous bladder, actually. I think it will not be enough to address only the reflux that's going on in the lower part, but you need as well to direct your attention to the bladder itself.
Okay, sir.
It is a high pressure bladder, and I think if you do a urodynamic study, assuming that the compliance, of course, will be baffled by the reflux and the diverticulum, actually.
Yes, sir.
But the end point pressure or the leak point or the detrusor leak point pressure, if he's having multiple contractions, you'll find it above 40 centimeters, especially if you take one vent. When you do your nephrectomy and reimplant, you're taking one vent of the pressure. So it's going to be more dangerous even. So you need to figure a way how to drain this bladder post-operatively.
Okay,
Otherwise, this patient might compromise his left side as well.
Okay, sir.
Is he continent, by the way? Sorry to interrupt. Is he continent, by the way?
Yes, sir. Yes, sir. He's continent, so he's passing urine normally.
Yeah, this is more dangerous even. This is more dangerous. Anyway.
Yeah, one query from my side. You said right side duplex system.
Yes, sir. Yes, sir.
That lower moiety is hydroureteronephrotic.
Yes, sir.
Both the ureters are joining in the distal course before
Yes,
it
sir.
enters in the bladder.
Yes, sir.
And the child is grade 5 VUR.
Yes, sir.
On MCU.
Yes, sir.
So the reflux, how it is affecting only the lower moiety?
Sir, diverticulum mostly right lower moiety is arising from the right around the diverticulum, sir.
So then how, I mean, both ureters are not joining, no? Then
No, sir. No, sir.
moiety load.
No, sir. It's not joining together.
Okay. Because in your presentation, I think everybody felt it is joining distally.
No, sir. No,
So
sir.
they are separately opening into the
Separately
bladder.
opening. Yes, sir.
Okay. Because that was a query also asked by Dr. Narendra Babu. Another question from the Dr. Shatis. Waiting on this case just made the bladder more and more neurogenic by not doing any intervention, as Dr. Serif has already explained. You will need a catheterizable stoma in the bladder to empty it better. That is a suggestion from Dr. Satish. Narendra Babu, was the ureteric moiety joined really or opening separately? So it is opening separately. That is Dr. Imran has answered. Gaurav Sandilia's query is RGP needs to be done before proceeding. Now, Imran, you want to take
Yes, sir.
this question? RGP needs to be done before proceeding?
Sir, as MRU source, there is I mean, it's duplex system. Don't think we
I
will
mean,
get
you
a
may
much.
not be able to do it, basically.
Uh-huh.
Even if you attempt, you may not be able to see the ureteric opening in the diverticulum, and you may not be able to do RGP.
Yes, sir.
So, I mean, whatever you plan, you will have to plan carefully and early. Are there any more queries?
Ureter could not be visualized, sir, in cystoscopy separately. Right
Yeah,
side.
so you can't do RGP in that
Yes.
scenario.
Can I ask
Rajendra?
one?
Yeah,
Yes.
please go ahead, Rajendra.
Yeah, this is about the first case, not
Yes,
about
sir.
this case, second case. First case, you gave that child presented with two episodes of urinary retention. Isn't
Yes,
it?
sir. Yes, sir. Yes, sir. First case.
Now, that child was given alpha blocker after the
Yes, sir.
first retention.
Yes, sir.
What was the basis of this? And you continued this alpha blocker even after operation. Yes. What was the basis of administering alpha blocker after the first retention? Yeah, you found out that already. You found out that child has a urinary as a bladder diverticulum, and which can be the cause of a distended diverticulum pressing upon the bladder neck can be the cause of retention.
Yes, sir.
What was your basis for giving alpha blocker in this case?
Just to relax the sphincter, sir, or to prevent the retention.
I think it may not be needed because it is mechanical pressure upon mechanical pressure of the distended diverticulum upon the bladder neck, which caused the retention.
Okay, sir.
So,
Well, I'll just take the same point. Actually, I think alpha blockers will be needed for the second case. I think, but I believe that you have a problem that we usually face in our part of the world as well, is the problem of the non-compliance or infrequent attendance to the clinics. If you ask me what I would do for this boy in the current status, I would add a mitrofenol for this boy and slam him to the wall with alpha blockers and follow him up. But this is an ideal situation. But in this part of the world, our part of the world where there's a problem in follow-up, I would suggest that you take, I mean, is it applicable that you proceed in this particular family with CIC through mitrofenol or not?
So we can convince them, sir, at around 7 to 8 years of age. If the child is having continuous incontinence, people are accepting now, sir.
I mean, beyond acceptance, even, I mean, regarding the possibility of this family handling and buying the Nelaton catheters, etc., is it possible or not?
Yes, sir, it is possible, sir.
It is possible.
Yes, sir.
So I suggest that you add a mitrofenol and alpha blockers for this case as well.
But our child is symptom free, sir. There is no child was asymptomatic.
I mean, for the most part of his life, he's been asymptomatic, but he lost his kidney, and now you are removing the vent. The vent is a huge diverticulum and the grade 5 VOR on the lower moiety on the right side. So expect to see the ugly face of this bladder once you take these out. That's the point. So he needs a very tight follow-up, or prophylactically, if they can do a mitrofenol, then I would construct a mitrofenol and slam him to the wall with alpha blockers. Otherwise, you are risking the other side and the lower moiety of the affected side as well.
Okay, sir. For this patient, since the child was asymptomatic, I don't think we can convince the parents for mitrofenol, sir. They might not accept it.
Yeah. Query from Dr. Jitendra. Is there any role of Botox? Yeah. And Narendra Babu has asked Euroflow for the second case, whether it was done or not.
Euroflow is done, so I showed the image.
Yeah. Narendra, that's the Euroflow. Role of Botox, you want to take that question?
Not sure, sir. I don't think it is helpful in this case.
Yeah. If there are no more questions, we can go over to third presentation. Nice cases. Only thing I think these two diverticulum cases you should have presented separately. Both were little complex and it's not very easy to understand both the cases together. So separate presentation, separate question answer would have been little better. Can we go to the third presentation by Dr. Jayakumar?
No. Before Dr. Jayakumar, case presentation by Dr. Bhavana.
Okay.
Dr. Bhavana is a second year MCH trainee at ESI Medical College, Hyderabad, Telangana State. Dr. Bhavana, please.
Good evening, everyone.
Good evening.
Good evening.
Today I'm presenting the challenges that we face in managing a pyeloplasty, which was done in a hugely dilated kidney. So we had a child who was 10 years old, neglected case of antenatally detected bilateral hydronephrosis, which was detected at 36 weeks of gestation. But the child did not have any postnatal follow-up. At 1.5 years of age, the child was misdiagnosed as nephrotic syndrome and was managed with steroids for 6 months. We currently don't have any documents of that time, but this is what was told by the parents. And even after those 6 months, as the child was asymptomatic, there was no further follow-up which was done. And the child remained to be asymptomatic till 10 years of age. So he presented to us with complaints of vague bilateral flank pain and fullness. There were no urinary symptoms of dysuria, pyuria, or hematuria, and no history suggestive of UTIs. So we started our evaluation with getting an ultrasonography done, and the ultrasound showed hugely dilated bilateral pelvic ileal system with a APD measuring 7 centimeters on the right side and 7.2 centimeters on the left side. And the renal parenchyma was thinned out in bilateral kidneys, and it was negligible on the left side with only 3 mm thickness of the renal parenchyma. The distal ureters could not be seen. But as it was case of bilateral hydronephrosis, we proceeded with MCUG, which was normal. Next, we got dynamic renogram done. So in the perfusion phase, we can see a very thin rim of renal parenchyma on the right side. Left side, it's even thinner. And in the drainage phase also on the left side, there's hardly an accumulation of the radio tracer. On the right side, there is gradual accumulation, but there's barely any drainage. It was reported to be a case of bilateral obstructed system with differential function being 27% on the left side and 73% on the right side. We have clinical meets with the nuclear medicine department at NIMS Hyderabad every month where we discuss such complicated cases. And in that they had told us that the function reported was overestimated because of gross hydronephrosis. And the more accurate function on the left side was reported to be only 20%. So our working diagnosis at this point was bilateral pelvic-ureteric junction obstruction with better functioning right kidney. The question in hand was which side to operate first. Usually the symptoms of the patient and the renal function are considered. And in centers which are capable of doing bilateral pyeloplasty in a single sitting is an option. But in our case, there were no symptoms specific to one side. So we went ahead with the option of doing pyeloplasty on the better functioning kidney. So right Anderson-Hines pyeloplasty was planned first. So as an institutional protocol, we do cystoscopy and retrograde pyelography before proceeding to pyeloplasty in all cases. And in this case, it had shown hugely dilated bilateral pelvic ileal system. So there was no significant drainage of the contrast even after 20 minutes. So we proceeded with pyeloplasty. So intraoperatively, there was a huge intra and extrarenal pelvis. Extrarenal pelvis was reduced. The renal parenchyma was also good. So we proceeded with standard right Anderson-Hines dismembered pyeloplasty in this case. And 4-French 20 centimeter transanastomotic stent was placed. The postoperative course was uneventful and the DG stent was removed at 4 weeks as planned. And next we were planning to proceed for left pyeloplasty. But before we could do that, the child presented with high-grade fever and pyuria. And the urine culture showed significant growth of Pseudomonas aeruginosa, which was not sensitive to any of the antibiotics and had only intermediate sensitivity to colistin. So we postponed the plan of left pyeloplasty and proceeded with left percutaneous nephrostomy. And we're planning to do left pyeloplasty after 3 weeks. So during these 3 weeks, the child was stable on left PCN. So we proceeded with left pyeloplasty. Intraoperatively, there was extensive fibrosis, which was extending from superior pole of the kidney to inferior pole, and even the proximal ureter was densely adherent to the psoas in the retroperitoneum. And after almost an hour of delicate dissection, we could locate the medially placed pelvis, extrarenal pelvis, which was hardly half a centimeter. And the entire hugely dilated PCS, which we had seen on RGP, was actually all intrarenal. And the renal parenchyma also was extremely thin, giving an appearance of bag of water. But we could dissect the pelvis, pelvic-ureteric junction, and we could excise the segment. And we proceeded with the standard Anderson-Hines pyeloplasty. Transanastomotic stenting with DG was done with 4-French 20 centimeters DG. And we had kept in the left PCN, which was inserted before, and it was kept on continuous drainage. Because of these unusual intraoperative findings and poorly functioning kidney on dynamic renogram, which was done preoperatively, we proceeded with left renal biopsy, which showed a normal report. So postoperatively, initially the child was stable, there were no symptoms. So we had clamped the left PCN on post-op day 12. So within few hours of clamping, the child had developed pain and left flank pain, left flank mass, which we felt was unusual because the left digestant was still in situ. So we got a check X-ray done, which showed a slipped out digestant into the distal ureter and the bladder. And since it was only 12 days post-operatively, we went ahead and did reinsertion of the digestant. And the PCN was kept clamped. The child was asymptomatic. And as planned, the digestant was removed after 3 weeks. And immediately, and within few hours of digestant removal, the child again developed symptoms of Dietl's crisis, where he developed left flank mass pain, which relieved promptly after unclamping the PCN. So at this point, our working diagnosis was possibility of an anastomotic stricture. And the only point in favor of that was the extensive perinephric fibrosis that we had encountered during the intraoperative phase. But other features were not suggestive of an anastomotic stricture. Like the digestant went in very easily. We had done a RGP again, which showed free flow of contrast and the ureteroscopy findings, which I'll be showing shortly. So when we did the retrograde pyelogram again, there was free flow of contrast, as we can see here, and there's no features of any stricture there. At this point, we had planned to insert a silicone digestant, which can be retained for a longer period of time. And also we wanted to absolutely rule out any remote possibility of there being an anatomic cause for the obstruction. So we planned to do a ureteroscopy, which revealed an interesting finding this time. So initially, when we attempted to do ureteroscopy, we faced difficulty negotiating the scope across PUJ. So we passed in a ureteric guide wire. So as you can see here, the pelvis is full and there's coiling of the ureteric guide wire at the level of PUJ. And after we unclamped the PCN and the pelvis has drained, the guide wire went in very easily. There was no coiling. And even the 4.5, 6.5 French ureteroscope, we could negotiate it easily across the PUJ. There were no synecdoche or narrowing or anything in the ureter. So at this point, our hypothesis was that when the pelvis is filled, the huge kidney is drooping and causing a kink at the PUJ, which is leading to obstruction. And as we are unclamping the PCN, the pelvis is getting drained. There's no more drooping of the kidney onto the PUJ. The kink is relieved and thereby the obstruction is getting relieved. So after that, we had repeated a nephrostogram also to look for the drainage. It showed slow prolonged drainage, but it was not obstructed. And a repeated dynamic renogram also confirmed those findings. It showed improvement in the drainage pattern of bilateral kidneys, but a right side was improved more than the left side. And the differential function on the left side has also increased now to approximately 30%. So to summarize, this was a case of bilateral PUJO, wherein the first better functioning right kidney was operated first. And because of left pyonephrosis, left PCN was done before proceeding with left pyeloplasty. And as the digestant was removed, the child was developing features of Dietl's crisis. So we had inserted a digestant and kept in situ for almost 4 months. And after the removal, the child had to be kept on continuous drainage of the PCN. So at present, there is no digestant in situ. The left PCN is still there and we are intermittently unclamping the PCN. Like initially, we had to unclamp the PCN every 3 to 4 hours because child would develop pain and flank mass. But now with gradual progression, we are requiring to open it only once in 3 to 4 days. And the child is asymptomatic right now. The renal function is preserved. And we had discussed this case with other pediatric surgeons and we came up with these 2 options for further management. The first one being a ureterocalicostomy. And also we are looking at the role of nephropexy in this case because that is our hypothesis that the drooping of the kidney is causing obstruction at PUJ. But we couldn't find any extensive literature on pediatric nephropexy cases. So now I'd request the panel to discuss further on the management options for this particular case.
Yeah, Dr. Serif. Please.
Well, yeah, thank you so much. It was a very nice presentation for yet another complex case. To start with, I would do as much as you've done. I did address the better functioning kidney in this boy. And regarding these hugely dilated kidneys, actually, you might expect, you don't expect much of them on the long term. At 20%, 23%, this is technically not contributing much to the global renal function. However, given the numbers that are generated by the nuclear medicine department, you find yourself obliged to do something in the conservative side in order to retain these kidneys. Well, I have some observations regarding this particular case. The first, when I find extensive fibrosis like this with a hugely dilated kidney, I would go straight away for a very low erythropilostomy or a ureterocaricostomy from the very beginning, because the drainage of these hugely dilated systems is much impaired, and they do not have much ability to contract against even a patent PUJ. That's one. And the second one is that the kink is apparent from your RGP at the beginning. The kink is quite apparent. Despite passage of the dye, it passes, yes, but the kink is there, and it was quite evident, and it explains the pain that the boy was in. The third is the passage of the URS or the ureteroscope is different in the reverse direction, is different from passage of the urine in the normal direction. The URS can pass easily without any problem sometimes, but the urine as a fluid propelled only by the GFR, okay, is another issue. So I'd be careful in assessing the UPJs or PUJ obstruction with the aid of ureteroscopy. The last thing that I would like to add is, for this particular case, I would proceed directly for a ureterocaricostomy. I wouldn't rely much on clamping and declamping, because this is a temporary solution, actually. And once the fibrosis inches and things stabilize, you will find the recurrence of symptoms again in an already decompensated kidney. The role of nephropexy is not that much appreciated in our literature, and still it's not a 100% accurate procedure. Thank you so much.
Yes, thank you,
Yeah.
sir.
You want to answer anything, or the comment from my side? I completely agree with Dr. Serif. Ureterocaricostomy is a better procedure in such a scenario. If anyone remembers, in the first meeting which we had, first webinar of SPU, Miss Society of Pediatric Urology, where we presented giant hydronephrosis, where finally we ended up doing ureterocaricostomy, where initially function was 9%, and slowly on nuclear studies it went up to 45%. But there we ended up doing ureterocaricostomy, so that is a better choice in such a scenario. Another thing is why we don't like to do bilateral pyeloplasty in one go is if there is infection, then both the system will get affected, and then there is a problem. So that is generally we don't like do it on one side, and then at the time of removal of DJ stent, you can consider doing on the other side. Apart from that, there are some queries from the delegates. Let me just
Can
go through that.
can I ask a question?
Yeah, please.
I am doubtful whether they did sufficient reduction during the pyeloplasty. Was it? Did you do a reduction or not?
On the left side, there was barely any extrarenal pelvis, sir. It was all intrarenal pelvis. So we couldn't really reduce anything.
So
that is one problem. So we think results from large residual pelvis plus. So in that case, the anastomosis becomes something like a non-dependent anastomosis. That may be one of the main reason why it is not properly drained. So we have to think retrospectively whether from the operation finding itself, we should have planned ureterocalycostomy in the first setting.
Dr. Suhasini here. Sorry to interrupt.
Thank you.
Yeah,
Hello, sir. So good
Suhasini.
evening, sir. Dr. Suhasini, sir. Sir, this is our case, sir. So I just wanted to add on, sir, because on the right side, we faced absolutely no issues. And post PCN pyeloplasties, we have done quite a few of them due to late presentation, sir. But the left side was extremely unusual intraop. It was something like retroperitoneal fibrosis. I wouldn't want to use that term, but intraoperatively, there was extensive fibrosis, not just of the kidney, but ureter. So it was very difficult to even localize the pelvis and mobilize the ureter for the PUJ, for the pyeloplasty, sir. So that is why we did not keep ureterocalycostomy as the first option. Because once we saw the PUJ and we thought at least let us deal with it straightforward. And if we were to anticipate, that was the second option. I'm not sure if it was a wise decision, but that's the reason we didn't do an upfront ureterocalycostomy, sir. And secondly, at this point, yes, sir, we are intending to do a ureterocalycostomy. The clamping and unclamping was just to gain some time, sir, because he did develop one episode of pyonephrosis in between when we were doing this. So to gain some time, sir, number one. And number two, we are anticipating whether if during the ureterocalycostomy, because of this so-called fibrosis, which we faced the first time, if we are to face something similar, then what would be our option, sir? I would want guidance from all the seniors.
Come again, the question, what did you ask?
So when we go in for the ureterocalycostomy
Yeah,
now, if we
yeah,
are faced with that extensive fibrosis, which we had seen the first time, and
yeah.
find difficulty in mobilizing the ureter to bring it to the calyx, then what would be our options on table, sir?
I don't think you will have problem with that because the ureter, I mean, the kidney is very large.
Yes, sir.
Cortex is very thin.
Yes, sir.
Identification of ureter may be a little bit challenge in fibrotic area, but if you have put a stent or ureteric catheter by doing cystoscopy, you should be able to identify the ureter. And then, I mean, you should be able to do ureterocalycostomy. It may
Sir,
not be very easy, but you should be able to do it.
so my concern is if we have to pull the ureter so that it reaches the calyx, would it not kink this new anastomosis also? I mean, I'm just
No,
thinking
no,
of
it
the
is
term.
a straight path from lower calyx. It goes straight down inferiorly. You don't need to pull it.
Yes, sir.
It
Yes,
will
sir.
be a straight course. In fact, the ureter will be going straight up, and because of hydronephrosis, it will turn medially. So, right now it is kinking. But
Yes, sir.
once you mobilize, it becomes a straight course. It is not oblique or it won't be creating kink.
I
And that
quite
is
agree.
why the ureterocalycostomy will be a better choice.
I quite
Yes,
agree
sir.
with you, Professor Rashik. Actually, in the strategy or the tactic that you use in these cases is just to drop away. I mean, just forget about the scarred area up there. Okay, attack directly the lower calyx, away from the fibrosis, away from everything that has been done before, and just hinge the ureter. You will find it just close, very close to it, and the healthy part of the ureter should be there, and you just hook it up to the lower calyx, and already the kidney is thinned out, so you shouldn't find much difficulty in doing it. I hope you the best of luck. I have just one final question for you. Have you seen the blood pressure of this boy after correction?
Yes, sir. We are
Yeah.
keeping under close surveillance. As of now, we are not requiring any antihypertensives. It's on the normal side, sir. But we are keeping under close watch, looking for any trouble. But as of now, he's with maintained blood pressures for normal percentiles for each.
Yeah, because my experience actually in some of these cases, once you correct it and everything is very fine actually without any complication, they tend to develop intractable hypertension. Some of these even presented and needed nitroprusside in order to relieve hypertensive encephalopathy in some of these patients. Not quite large number, but some of them present like that. So I would be just a little bit careful with their blood pressure, at least 6 months to 1 year after the procedure. And I hope you the best of
Yes,
luck
sir.
in your
Yes, sir.
challenging case.
So
Best of luck.
Arvind has asked a valid query. when you were doing right side pyeloplasty, why did you do RGP on left side, which is an obstructed system, which may be the cause of infection, and then of course the fibrosis may not be just because of that particular RGP, but in infection it may be because of previous infection. So I mean, any particular reason why you did it?
Not really, sir. Basically, I think it was more of a time-saving procedure that we finish the bilateral RGP and go in 3 weeks and then finish the next procedure.
Okay.
So yes, it was probably now retrospectively not the best decision.
Yeah.
But that mainly it was a time-saving thing, sir. So that next time we can go directly with the pyeloplasty.
Yeah. Okay. Very nice case. Very good presentation.
Thank you all, sir. Thank you all for your guidance. We'll keep you updated what we do, sir. And,
Yeah. Thank you.
Thank you so much.
Rajendran, last presentation now, no?
Yeah. Last presentation by Dr. Jay Kumar.
Jay Kumar, please start.
Jay Kumar, Dr. Jay Kumar.
Yes, sir.
Dr. Jay Kumar is a government medical college. No, he is a medical college faculty assistant professor in a medical college in Salem. He has got a special technique of dealing with hydrocele, minimal access technique. That is what he is demonstrating. Dr. Jay Kumar, please.
Yes, sir. Can you see my screen?
We can see.
Okay, I will switch off my video because most of the slides are videos, so there will be a disturbance. Okay, thank you, SPU-IAPS, Dr. Prabhu, and the chairpersons. Why I didn't put hydrocele repair? I simply put PV-SAC, minimally invasive approach to PV-SAC. Dr. Rashik usually accept with me that we don't think both are different. Hydrocele and hernia are same pathology, so we have to deal it in the same way. Wait a minute, my slide is not moving. Yeah, I'm going to give introduction. Why a laparoscopic PV-SAC ligation and anatomy of the PV-SAC and the classification given for the hydrocele, different presentations and its management, and some precautions what we have to do, and conclusion. The introduction, laparoscopy is the main armamentarium in minimally invasive surgery. And PV-SAC is the common condition treated by pediatric surgeon. But less than 22% of the people are doing lap hernia in children as per a survey. Coming to the hydrocele management, it is very rare. Anatomy, normal anatomy is at birth or after birth, the process of vaginalis will get closed, only tunica vaginalis remains. When there is a patency, it will cause a communicating hydrocele if the opening is small. If the opening is large, it is going to cause the hernia. It can cause fluid hernia or a normal hernia with contents. When there is a hydrocele in the closed sac, mostly we are not dealing in pediatric. The primary hydrocele is common one, not the secondary one with the secondary causes. Coming to the classification by Cheng et al., there is a type 1, which is a encysted variety where you can't see any opening from the internal ring. There is no communication as per them. In type 2, it is funicular variety like hernia. In type 3, with the connection, there will be a cyst, single or multiple cyst, like encysted hydroceles. To add confusion, this a study from Egypt added few more type 2s. So as a surgeon, I don't bother these types. My pathology is patent processes vaginalis. I have to deal it. So coming to the surgical port, the port may be one camera port is must 5 mm mostly, and one or two working ports. If we are doing percutaneous needle technique, maybe without port also or with a single working port. If it is a conventional PV sac management, it is 2-3 mm working ports. This is how I do through the percutaneous needle technique. I keep a loop of proline and another proline to close the sac. But now I stop using this percutaneous technique. Now I move to the conventional technique. This is in the percutaneous technique. What we are doing is with the stab incision, we will go around the sac from outside. We will pull the thread from one side to other side by using the loop and close it subcutaneously. Because of the granular formation, I stopped using proline first. Then I started using Vicryl. I didn't get any recurrence in hydrocele, but I got 3 recurrence in hernia. So I stopped using this percutaneous technique. This is a female hernia. Why this was posted is this is for the residents and young consultants who want to start hernia surgery. Always start dissecting from the upper outer quadrant of the canal. Just open the sac, upper outer quadrant. Keep the sac with the left hand and cut the sac 360 degree. This is a female hernia. So if you are injuring the round ligament, it is not going to do any harm. Try to preserve the round ligament just to practice. When we are going for a male hernia, it will be very useful. While cutting, I am using mild current to avoid bleeding. When this is only, I am using current for a female hernia, not for male hernias. Just try to push the round ligament from the sac. Actually, pushing the vas and vessel is very easy. Round ligament is not that easy. Now cut the sac at the medial side. Now shave off the round ligament from the sac. Now 360 degree, the sac was cut. Now close the sac with any material. Observable material also fine. Once we cut the sac 360 degree, enough. We can do it by intracorporeal or extracorporeal, any method we can use. One of the surgeon from here, senior surgeon, don't close the sac at all. When we go and see, there is a hole in the at the distal port. We can see a hole. This is the basic for the encysted hydrocele. Now coming to the infant hernia, this is the right side hernia. We can see a patency in the left inguinal left deep ring. what we have to do is we have to close both the sides. This was done with the percutaneous route. Both the rings were closed. Left side hydrocele also settled with this. This is the retractable testis with hernia. Now the camera is inside the scrotal sac. We can see a peritoneal fluid inside the sac. Because of the wide opened sac, we are not getting hydrocele here. We are getting the hernia. Closing the deep ring with any method is enough. This is coming to hydrocele. This is a right-sided hydrocele. Just twist the scrotum slowly. Don't give much of pressure. The fluid will get drained mostly. Again, there will be a see what I am doing is I am causing intentional peritoneal injury in the right upper front up to the tooth. Then I will close the deep ring. This is bilateral hydrocele. We can see both the internal rings are open. When pressing the outer from the scrotum, press it slowly. Otherwise, it will not allow fluid to come inside. Maybe because of reversing bottle effect or flap valve or the ball valve mechanism. This is the right side hydrocele operated patient. Within a month came with the left side hydrocele. Open repair done. So it is better to go with the laparoscopic repair. This is the right side encysted hydrocele. Even though it is encysted, we can't see a hole. But when pressing from outside, fluid is draining. It means there is a communication. Most of the encysted hydroceles are communicated. There will be an opening, which we are not seeing. That's all. What I am doing is just I am draining the fluid from inside. Then I will do intentional peritoneal injury without affecting vas and vessel. Then I will close the deep ring. Nowadays, I'm doing herniatomy. This is the encysted hydrocele. Camera is inside the canal near the superficial ring. We can see a small hole down with in the hydrocele. This is other hydrocele. We can see a small hole and a peritoneal flap. When you are pushing the scrotum, it will come and close the opening. It may be a ball valve mechanism or flap valve mechanism. It is closing. See, if you want to drain the fluid, you can go with the camera help and just poke the hydrocele without damaging the vas and vessel. Just open the jaw and get it out. You will drain the fluid. But it is not necessary. Previously, I did it. Nowadays, I'm not doing. Just closing the ring is enough. When you can't go with the camera and Maryland, just putting the Maryland towards the upper outer quadrant of the cyst, we can puncture it. Nowadays, I'm not doing this. This blind procedure is not good. If we close the deep ring, the hydrocele will disappear in 3 to 7 days. This is another case of hydrocele. Right, actually, we can see the left side pattern. See, this is a right encysted hydrocele. What I am doing is slightly pushing right encysted. Even though encysted, just giving slight push, we can get the peritoneal fluid inside. The same patient, I am doing just excision of the, I want to do the herniatomy at the deep ring. Usually I do off to 1 centimeter mobilization of the deep ring. I don't go distally. But this case, when I started mobilizing, the cyst just started coming. This is a multicystic type 3B. But whatever it would be, our main aim is not about the cyst. Our main concern should be vas and vessel. Preserve vas and vessel, close the deep ring. It's enough. It will get cured. This is another patient. For demonstration purpose, we have mobilized the sac for sac distally. After mobilizing, while cutting the sac, mobilize more, cut less, because vas is always coming with the sac. Sometimes we may damage it by mistake. While cutting the sac, most of the time I am using a hook diathermy or scissor with the diathermy. The reason is I don't want to make any hematocele. This is a case of left abdominoscrotal hydrocele. While pushing from outside, the whole cyst came inside. I can't see the opening, but there will be an opening. If you ask the history, the parents will tell the cyst will on and off. See, now medially vas, laterally vessel. In between the vas and vessel, I am opening the sac and extend the opening up to the deep ring. Then close at the deep ring. During the closure, I got a minor prick in the blood vessel, got the hematoma. It is not going to cause any harm. This is another case of right side hydrocele. But when I go and see, I can't see any opening. But I can see there was a membrane-like structure. But when I come to the left side was patterned. Initially, we thought it is a wrong side. But then we realized it is a abdominal scrotal hydrocele which drained by itself. Then we removed the sac, both sides, and closed. This is another bilateral hydrocele. We can't see much opening. See, by pulling the testis from down, we can see the opening in the left side. Patient came for the right side opening was somewhat bigger. So the same patient, right side dissection started. See, always start from the right upper quadrant. Within 2 strokes, we can separate vas and vessel. See, vas and vessel gone down. Now you can just encircle the ring and close it. This is enough for hydrocele. No need to go down and removing the excess sac, which is we are causing more harm by dissecting the vas and vessel unnecessarily. We are causing fibrosis. But for the same patient, for the demonstration purpose, we went ahead and go inside and see how long we can go. But this is unnecessary. For hydrocele, just close at the deep ring. Don't mobilize more. I'm using blunt scissor. Don't bother. There is a blunt scissor I am using for the mobilization. See, once we can get there is a connection where the fluid is coming from when we're pressing from down.
Jaya, I think
Yes, sir.
you have conveyed your point. You want to conclude?
Yes, sir. Yes, sir. Two or more, sir. Just final, sir. Yes, the same patient. The ring was closed. Sometimes we have to close the muscle also. If it is a large opening, it's muscle. We have to close the muscle. This is to avoid missing the sac. Pull the scrotum from down. There was no opening. This is another patient. It looks like an opening, but what we have to do is put our instrument and move the flap. There was no opening. This is another patient with a peritoneal flap, which is covering the deep ring. I want to see whether there is opening or not. If we miss it, we will miss the hydrocele. It will recur on the opposite side. This is opposite side. Right side already operated, already over. When there is doubt, explore the ring. See, but simply dissecting few strokes, we can identify the hydrocele from the opposite side also. See, this is the hydrocele. My experience is very less compared to the seniors. My total hernia and hydrocele is only 208. I had 3 recurrences with observable sutures. During my first 64 cases, 1 near miss for VAS with poor vision. Even for hernia surgery, go with a good camera system. And to conclude, the hydrocele repair have the MIS benefits, and we can deal the bilateral patency, and it is diagnostic. We have diagnosed a complete androgen insensitivity during the hernia repair. So thank you, SPU and all the persons.
Thank you for excellent presentation. Dr. Sherry, if you want to comment.
Yeah, I would like to play the devil's advocate here. Dr. Kumar, what do you think the
Yes, sir.
advantage, where do you think the advantage of your procedures that you have elegantly demonstrated in primary cases? What's the advantage over the good old-fashioned herniotomy that all pediatric surgeons practice worldwide?
No. This is minimally invasive approach. A herniatomy, you can do it, but we can see the bilateral patency. In laparoscopy, we can see the bilateral patency.
So you think this is the advantage, the only advantage that you have in primary cases?
And not only advantage, in the open repair, what we used to do now, we can do it with a 1 centimeter incision, 1.5 centimeter incision also. But what people used to do now, we will pull the sac, vas, and vessel, everything in our hand and separate everything. We are causing more harm. There will be what is the effect of fibrosis happen after the surgery? That is the reason I want to stop with the internal ring closer only.
Well, I doubt that many would agree with your point of view in this regard, with these justifications. But let me tell you, in secondary cases, yes, it definitely has a role. Bilateral patency is a visual inspection rather than a clinical correlation. This has been proved by a very large series of hernias coming from sick kids. And finally, the message, I know that there is a lot of trainees here and junior surgeons around. Probably laparoscopy and minimum invasion has its glamour and has it's there and it's staying. But again, the junior trainee, the junior doctor, the junior surgeon needs to master the open technique before embarking on the laparoscopic technique, especially in a procedure where injury of the vas is quite easy in inexperienced hands. That's the point. Putting that aside, it's an excellent presentation, excellent procedures, but the big question is what's the advantage over the conventional one? Thank you so much.
Yeah, thank you, Dr. Sherry. It is going to remain controversial whether hydrocele hernia should be done using minimal invasive technique, whatever you want. There are many different ways people do it, or doing it open. I don't think we are going to get any easy answer in near future. But what Dr. Jayakumar has showed, the way of doing hydrocele hernia repair laparoscopically, it's a good technique. There are few suggestions from my side. One is there was a lot of buffering, Jaya. So you did switch off your video to decrease the buffering. But another thing one may do it is downgrade the video quality to start with, means when you are saving. so that the buffering will be less on the other side, because your movie may not be getting uploaded very fast because of the internet, which if it is slow. That was one. Second, instead of using scissors for cautery, it is, or while using diathermy, it is better to use hook. Then you
Sir, I am
will,
using both.
yeah, but don't
I am
use
comfortable
scissors.
with both. Yes, sir.
Don't use scissors because the
Yes, sir.
scissors will get spoiled. That is
Right.
one. Second is scissors has a long open metallic area which is not insulated.
Yes, sir.
So it's always, particularly when you are doing in a small child with less space, hook is always better. In an older child, again, the scissors will get blunt, so it is better not to use that. And another question which I have, in a patient where there was hernia with the testes which was retractile, did you fix the testes or you left it like that?
No, I left it because I have. I am not only doing pediatric. I am doing adult also. Well, after dissecting the deep ring and the sac, the testis will come down.
Okay.
Dissecting the sac, the testis is coming down. I have noticed in the male hernia, adult hernia also, where I did hernioplasty, laparoscopic herniaplasty patient. I have noticed in a 25-year-old male. That once we dissected the sac and pulled the testis, it is coming down very off to 1 centimeter. It is one more thing. It is retractile. No need to fix, I hope.
Okay. So in general, at the end of any laparoscopy hernia repair, it is always better to check that testis is in the scrotum. Sometimes one can pull it and then create iatrogenic undescended testis, like what you do in open. Same thing you have to do it even in laparoscopy, particularly if you mobilize the sac and excise it. Then it is always better to pull down the testes and make sure it is in the scrotum. Are there any questions from delegates? What are the panelists' thoughts on laparoscopic closure of internal ring without dissection of sac? So as far as if you are asking me, since 2002 we excise the sac, we make an incision, dissect and excise the sac for 1 to 1.5 centimeter, and then close the peritoneal side. We had never migrated from this to any other technique because we have good results. We don't have any problem with that, hardly any complications, and we continue doing that, and almost zero recurrence over last 22 years. So there is no reason for me to change what we are doing over last 23, 24 years now. In male and female, both we do the same technique today. Anyone else will like to answer that? Dr. Sharif, I don't know whether you do lap or not for hernia, but in case if you are doing, you may answer. Yeah.
Well, I do it for secondary cases actually, and believe it or not, most secondary cases are after laparoscopy as well. That's the point. We seldom see a case after an open repair in a primary open repair straightforward case. But I reserve the lap only for the secondary cases, and I quite agree with you that using the hook is much safer. And probably another trick is using saline dissection as well in these cases, the recurrent cases that we do it. We use saline dissection along with the hook. We find that it is safer. The blade of the scissors is quite large actually for such an optic field to be comfortable to use it with the whole scene of the iron or the blade inside the camera view. So the hook is definitely better. And finally, we use, in these cases, we use non-absorbable sutures actually. Sorry, non-absorbable like Prolene or Ethibond. I don't have much faith in Vicryl in this situation, actually, especially when having a recurrent case. I wouldn't have I would like to have a third recurrence, actually. Thank you so much.
So we have been always excising the sac and suturing with Vicryl, and no issues with that in both primary as well as secondary. Though the number of secondary cases which I may have done recurrences are less than 10, because they are basically someone else's patient. If they come to us, then only we get chance to do secondary repair, and in that case we have used Vicryl, but of course we excise the sac for 1 to 2 centimeter and then close it. Yeah.
I prefer to do hernia by open technique, but because of its advantages over this laparoscopy, which is done under general anesthesia, it is really invasive for a herniatomy. But in left-sided hernia, because there is a chance of associated right-sided hernia also, in such cases, the laparoscopy repair may be advantageous to see the patent process vaginalis on the right side in left-sided hernias. Now for hydrocele, I don't think there is advantage, because even if there is a patent process vaginalis on the opposite side of the hydrocele, only a bare minority of them will in future develop hydrocele or hernia, and may not be worth to repair such cases. Now, because of lack of time, we are forced to wind up more than 1.5 hours.
Rajendran sir. Rajendran sir. I want to add one point. Why laparoscopy for hydrocele? Yes, sir. Why laparoscopy for hydrocele? I have a friend, 24-year-old, who is coming with us to play cricket. He came with a hernia, one side complete hernia. He want to do herniaplasty, laparoscopy herniaplasty. When we go inside, I can see bilateral. The problem what he have in childhood is he had hydrocele which was not repaired. If he repaired that hydrocele, now I have to put a 30 into 20 big size mesh into his abdomen. It's not necessary. So better if we go by laparoscopy, we can close the opposite side. It can avoid future herniaplasty using the mesh.
Okay. As Dr. Rasiksha pointed out earlier, that if we go on discussing, the discussion will not end. Let us stop here. I profusely thank the presenters, Dr. Muhammad Imran from Trivandrum, Dr. Pavana from Hyderabad, for their complex, typical, thought-provoking cases, teaching cases, and Dr. Jaykumar for his technique of closing the patent processes vaginalis, spotlight on his technique. I profusely thank again the chairs, Dr. Rasiksha and Dr. Sharif Suleiman from Egypt, for chairing this session and conducting the proceedings very well. Finally, I should thank our chairman, the chairman of the Society of Pediatric Urology, Dr. Prabhu Goyal, as well as Secretary Dr. Prabhu Karnagaran, for arranging this program very well. I also thank the participants who attended in large numbers, unlike the previous programs. It is an encouragement for us to continue with this international DSPU programs in DSPU in future also. Thank you very much from my side. I am handing over to Dr. Prabhu, the Secretary of SPU.
Oh, thank you, sir. I think we should be concluding this session in a while. And thank you, Ratik sir, for accepting the invitation in the last moment. And thank you, Mr. Sharif. And you know, we met in ESPU. It was very honored to be. I've seen all the way you discuss the bladder cases. It was wonderful to see both there and here as well. So
well, thank you so much. I appreciate your efforts and appreciate the group's efforts. It was a wonderful meeting. And I hope you join us in the similar Egyptian one in the very near future. Thank you so much, everybody.
Yeah, soon we'll have a collaboration between Egypt and India so that your residents also could come and present in such a platform.
Of course, definitely this will happen.
Yeah, sure. So
Thank you.
with this, thank you everyone. It was like more than so we'll look forward for the next meeting. And before we wind up, I would request the chairs and people who are interested. I would send across the PowerPoints and of these two cases, so you can give you a final verdict of what exactly your thought process on these three complex cases, so that the people who have presented this would actually get benefited out of it.
Definitely.
Thank you.
Thank you so much.
Thank you so much. Thank you for your time. Thank you, Rajendra.
Thank you. Good night.
Thank you. Good
Good
night.
night. Good night, everybody. Good night, everybody. Bye.